Hi, everyone. Thank you so much for coming. We really appreciate you taking the time out of your day to join us. We know that there was a little bit of the postponement, but we really appreciate you coming to tonight's lecture. So just to let you know, Fernanda did introduce herself in the chat. She's going to be tonight's moderator, so feel free to place questions in the chat and she can help answer them, and then we'll also have a Q&A at the end. Today, Bennett and I are going to be talking about insurance and socioeconomic determinants of health. So a little bit about me. I'm currently a D3 student here at UCLA. I did my undergrad at UC Berkeley, and here at UCLA, I'm one of the co-presidents of SIDE, along with McKenna and Kristen. And during my 2 gap years between undergrad and dental school, I worked in a pediatric dental office up in the Bay Area, and then also a general dentist office in New York City. And working in 2 major metropolitan areas on opposite coasts and with different patient populations really gave me a unique insight into some of the challenges of insurance and benefits and how socioeconomic status can really affect patient care. So both practices that I worked at did tend to serve more privileged populations, and neither of them accepted public health insurance like Denti-Cal or Medicaid. But still, I unfortunately saw many patients, even those with private insurance, that were deferring important treatments due to cost. So I really like talking about these issues and what we can do to help these patients.
And my name is Bennett. I'm a D2 here at UCLA, and I did my undergrad at UC Davis, where I got a degree in English. Currently, I am the ASDA Wellness Chair, and I'm also one of the vice presidents of the Healthy Dentist Initiative, which is just a club on campus. We also promote wellness in that club as well. I am super excited to be talking about this because during my own gap year between undergrad and dental school, I worked at Delta Dental, and I learned all about procedure codes, provider reimbursement, and how insurance can dictate treatment options, which not a lot of people know about, but unfortunately that can be the reality. And so it really challenged my blanket belief that insurance can always be a good thing, case closed. And we'll talk about that in a few minutes once we get to insurance. Next slide, please. Thank you. Cool. And so I'll start off by talking about socioeconomic disparities in health, and then I will move on to talk about insurance and how it works. From there, Allegra will pick it up, and she'll talk about socioeconomic disparities, which is on progress, promising evidence, and what we can all do moving forward as dentists and future healthcare professionals. And like we've said, Fernanda, she's our moderator today. Questions can be placed in the chat. She is there for you currently. Okay, cool. So according to the CDC, the social determinants of health encompass economic and social conditions that influence the health of both people and entire communities. These conditions are shaped by socioeconomic position, which is the amount of money, power, and resources that people have, all of which are influenced by factors like policies, culture, and societal values. On an individual level, socioeconomic position can be molded by various factors like education, occupation, and income. Despite initiatives and programs created to promote equality in education, in the workplace, and in communities, there are still rampant socioeconomic disparities that can have a drastic effect on one's health. And so the next few slides detail disparities in education, income, and wealth, factors all of which determine an individual's socioeconomic position, and they can affect the ease in which these individuals can seek opportunities. All right, so starting with disparities in education. Although education rates have been steadily increasing across all races throughout history, really, it's still worth noting the rather large disparities in education rates between white individuals and their Hispanic and Black counterparts. Black and Hispanic individuals are less likely to complete high school or higher education than their white counterparts, and you might be wondering what the causes of this are. Data from the National Equity Atlas found that the greatest predictor of racial gaps in educational achievement is the extent to which students attend schools surrounded by other low-income students. These researchers looked at the largest cities in America, cities like Chicago, New York City, and even here in LA. In Chicago and New York City, they found that 96% of Black and Latino children attended schools that were majority low income. And here in Los Angeles, which is really our own backyard, 85% of Black children and 96% of Latino children attend schools where a majority of their peers are poor. And it's not really that sitting next to these kids that makes one do worse in school. It's really that school poverty is a good proxy for the quality of the school. They're in poor communities with less resources, there are fewer parents with college degrees, and they have difficulties attracting and retaining the best teachers. This in turn can perpetuate cycles of gaps in opportunity, which can affect a child's life trajectory as they grow older. And so as we move on to discuss disparities in income, I thought it was worth noting here that although the education gap has narrowed over the years, the racial income gap has not. So talking about disparities in income is really talking about the racial wage gap. When the Civil Rights Act of 1964 was passed, it became illegal to discriminate based on race, yet these income disparities have not equalized. In 1968, following the height of the Civil Rights Movement and the assassination of Martin Luther King Jr., Black families' median income was 60% of white families. As seen in this graph, it remains 60% as large in 2008, despite the introduction of affirmative action in education and hiring, as well as anti-discrimination policies in the private and public sectors. To quantify that, researchers have found that Black families earn $57.30 for every $100 in income earned by white families. Further, Black children have substantially lower rates of upward mobility than white children, and data has gleaned that nearly 50% of Black children raised in the bottom income brackets remain there as adults when compared to only 25% of white children. This leads to gaps in income that are noted in the graph, which researchers believe can persist indefinitely without changes in intergenerational mobility. By closing the gap in opportunities afforded to children of various socioeconomic status, researchers predict that the income gap could be eliminated within only 2 generations. And while that's all well and good, opportunity means access to good schools, safe streets, neighborhoods, and the availability of recreation and enrichment, which means like after school programs and SAT prep. And while every child should definitely be provided these opportunities, implementing policies that could get us there as a nation is going to be an uphill battle. However, addressing the disparities in wealth, which we're going to talk about next, is a great place to start. Thank you. So moving on to disparities in wealth, you might wonder what the difference is between wealth and income. Wealth is the stock of assets held by a person or household at a single point in time, whereas income is money received over a period of time. So wealth is measured based on assets like cars, homes, retirement funds, and include debts as well. And so while the graph shows the drastic variance of wealth between Black and white families, the data on the slide highlights the striking disparities in asset ownership and value. And so as you can see, only 14% of Black Americans have retirement funds compared to 45% of white Americans. The median value of checking accounts varied from $1,900 for Black Americans all the way up to $9,000 for white Americans. Likewise, 49% of Black Americans own homes compared to 77% of white Americans. And this is actually really important for our next slide. So as it turns out, home ownership is the largest predictor of the gap in wealth growth by race. Residential segregation by the government underpins many of the challenges Black families face in buying homes and increasing equity. And equity, in short, is the difference between the market value of your home and the amount you owe on it. So as you pay off your mortgage and the property appreciates, your home equity increases and your wealth increases. Historical policies like the Jim Crow laws and redlining of minority neighborhoods have had lasting effects on the equity of minorities in America to this day. And so Kristen went over this in our last slide lecture, but just in case you missed it, the federal government created maps in the 1930s that coded neighborhoods as creditworthy based on both the race of the occupants and the age of the houses. And these coded neighborhoods were redline neighborhoods. Banks wouldn't authorize loans for mortgages in these redline neighborhoods, so minorities were unable to purchase homes where they lived, nor were they able to move to better neighborhoods with better schools. And so although redlining was outlawed in the 70s, the effects of redlining is still seen to this day. Black Americans are less suburbanized, and they're often isolated in urban communities with less access to transportation, jobs, healthcare, and better school districts. It's also worth mentioning that housing prices tripled in the 70s, and it was white families that reaped the benefits of this increased equity, which is the basis of historic wealth accumulation. And because of historic wealth accumulation, white families are able to currently, and since the 70s, assist their children with down payments on homes, which allows white children not only to start acquiring their own equity sooner than their Black counterparts, but it also means they have lower interest rates and lending costs on the homes they're able to buy. So this, in addition to differences in access to credit, lower incomes, and the residential segregation I've touched on, has led to lower rates of home ownership seen among Black Americans. And even when they do buy homes in historically segregated neighborhoods, the value of these homes are lower because of the perceived demand being lower, which means the homes cost less and the homeowners have less equity or wealth because of it. All right, so far we've touched on education, income, and wealth. Black and Hispanic Americans are typically in the lower socioeconomic groups than white Americans are, and the reasons are all interconnected. Children that go to schools in worse neighborhoods tend to have less opportunities, and opportunity can mean a lot of things, but something that I like to touch on is that they tend to lack teachers and educators that can encourage them and inspire them to dream bigger. And because of this, in addition to the historic racism that we've talked about, they're less likely to complete higher education and are less likely to get well-paying jobs that could allow them to accumulate wealth in the long run. And because of these differences in opportunities and their decreased likelihood of economic mobility, the cycle is repeated throughout generations, as is one's socioeconomic status. And so now we're going to move on to talking about the effects that this can have on one's health. And we'll start by talking about quality of care, and then we'll move on to access to care, and then we'll touch on health insurance. And so this slide details a study done at the University of Michigan where they studied the survival rate of esophageal cancer patients. And they found that the 5-year survival rate was significantly lower in those in lower socioeconomic status groups compared to those of higher socioeconomic status groups. They also found that the lower socioeconomic status patients were offered operative treatment at significantly lower rates. They had decreased rates of second opinions, and they were more likely to lose their jobs. And so if we take a look at the graphs on the right, we'll start at the top. Most notable that I think is that they were way less likely to receive or even seek a second opinion, and they were a lot more likely to lose trust in their position. And then moving down to treatment options, as you can see, they were offered operative treatment at lower rates. And then rounding it out with financial concerns, they were more likely to carry the burden of financial difficulties. And then most notable to me, although a lot of this is very striking, is that not only were they way more likely to lose their employment, they were the only ones losing their employment. They didn't find anyone in the study in the higher socioeconomic because of their illness, which is really sad. Next slide, thank you. Okay, so to further expand upon quality of care, these graphs show that the patients who were considered low income or poor, which is green and purple respectively, were more likely to rate their provider poorly when it came to accessibility, which is graph A, responsiveness, which is graph B, and communication, which is graph C. They were also more likely to rate their shared decision-making as poor and to leave unsatisfied following physician encounters. And this all serves to prove that lower income earning patients have poor healthcare experience in all aspects of access and quality of care. And that we really need to advocate for policies that focus on improving communication, engagement, and satisfaction in order to enhance the healthcare experience for this marginalized population. Thank you. Okay, so moving on to access to care, plenty of people have difficulties accessing healthcare services, but people of lower socioeconomic status are really in the thick of it. Common barriers to receiving care includes time, and that could refer to one's ability or inability to get time off of work. And people of lower socioeconomic status are more likely to work hourly jobs, where hourly positions generally require one to request time off weeks in advance, which is hardly accommodating because we don't really anticipate getting sick. We can't predict the future. Likewise, it's not uncommon to be penalized for calling in sick. And these job-related difficulties can be further compounded if there are kids that need to be picked up or dropped off at daycare, not to mention whether or not that's something that can be afforded on a whim for a family that's struggling financially. And so the infographic on the top right, highlights that less than 200% of the federal poverty level struggled the most logistically when it came to receiving healthcare compared to women who made more. Another barrier to care is provider availability. There are actually laws that require health plans to provide timely access to care. I've learned that's called the Knox-Keene Act in my research. And this means that there are limits to how long you have to wait to get an appointment. So in California, you have a right to get urgent care within 2 days. And that's great. There's a law that says we have a right to get urgent care within 2 days. But that can be a long time when you need urgent care. It's urgent. For non-urgent care, it's 10 days for a primary care physician and 15 days for a specialist. However, as we went over a minute ago, people of lower socioeconomic status really have to plan out health visits, and it's truly not as easy as logging on or checking when you have class and logging into the ASH portal or logging into Kaiser and just making it work for you. It's really just not as simple as that. And it's also worth mentioning that we're currently facing a physician shortage, and health advocates anticipate that this is only going to get worse over the next decade and will probably peak around like 2032, I think is what I read, in the 2030s. And so as you can see in the little graph on the bottom right, primary care physicians are outnumbered by about 20 per 100,000 people, which makes them a real hot commodity among people trying to get care. And so addressing this physician shortage and getting ahead of it before it could get worse can also help us mitigate access to care issues in the long run. And so additional barriers to care include transportation and financial difficulties that aren't always alleviated by health insurance. So as far as transportation goes, when I was doing research on access to care, I found an article published by the New York Times that highlighted where it was difficult to access hospitals that are necessary in the fight against COVID. And research showed that people are less likely to seek care, including emergency care, when they need to travel 30 or more minutes to a hospital. And so as you can see, more than 8.6 million people live in areas that are 30 more minutes away from the nearest hospital. And so not only does this become a matter of transportation, as a 30-minute drive could take hours to traverse on foot, and likewise, a lot of these places, especially like the light yellow or like orangey colors, those are rural areas where there are not always public transportation options. But it also shows the importance in increasing the accessibility of healthcare, like the physical accessibility, like how do we get people into the office sooner? And it's also worth mentioning, and I like to point this out on this slide, we've all heard horror stories about how expensive ambulance rides can be. And so being in an emergency situation over 30 minutes from a hospital, when they charge per mile, not only becomes a matter of life or death, but it can also financially ruin a family as well. Thank you. All right, so now we're going to go over health insurance. I'm going to explain how it works. I'll talk about health insurance, and we'll touch on dental insurance, and then I'll give you guys some more facts and figures. And so starting with private health insurance, I'll just touch on where you can get it. You can get it through your employer, you can get it through your school, or it can also be purchased through the health insurance marketplace. And if you don't know what that is, that was launched as part of the Affordable Care Act in order to make it easy to compare and shop for private health insurance. It just helps you get the most bang for your buck, and you can like compare plans on the website. It's actually really neat. And how it works, you have a yearly out-of-pocket maximum after which your insurance picks up everything. So that means that there is a set limit to the amount that you are going to pay. And after that, your insurance takes care of everything. Hopefully you've never had to use that whole maximum, but people that have multiple ailments, they might reach that pretty quickly, after which it's really nice to have insurance. And deductibles, copays, and coinsurance vary by plan. I didn't want to bore you guys with the details. I can go into the definitions if you want towards the end, but I just kind of want to leave it a little more simple and just talk about the maximums for now. But again, like I'm all ears later if you want to touch on that. But for now, I think we'll move on. And so private dental insurance. There's two types of private dental insurance. There are PPO plans and there are HMO plans. And so here you're looking at a PPO plan. You can get it just like you get your private health insurance. You can add it onto your health package with your employer, or you can get it through the health insurance marketplace. If you guys get it through school, you can also add it to your health package through the school. And so most notable that I want to mention, because it's what people will call about a Delta Dental all the time, is you have an annual maximum after which you pay for everything. And so that means that, let's say a common plan is the one you're looking at. So your maximum is $2,000. That's like denture, that's like you get your wisdom teeth out basically, and then you're done for. Like you don't even have room for a cleaning is what I would see a lot. And so that's very different from health insurance. How coverage works is, as mentioned, a lot of the plans that I saw were 180/50, which means that there was 100% coverage for preventative, which meant that the insurance company would pick up 100% of the cost, which is really nice, 80% for restorative, and then 50% for extractions, crowns, ortho, prosthodontics, etc. Also worth mentioning that in-network dentists have to adhere to a fee schedule. And so if you look at the image on the right, that kind of details what the benefits are of this fee schedule. And so if you look at the in-network dentist, let's say the dentist wanted to charge $1,200 for a crown. However, Delta Dental says, no, it's a little too high, you're in network, we're gonna save our clients on the cost. And so you're only allowed to charge $778. And so if this crown is covered at 50%, you pay half of that and you end up saving $811 because that accounts for what the dentist would charge you if you didn't have insurance. If we look at out of network, these dentists are allowed to charge whatever they want. So they're gonna charge all the way up to that $1,200 because they don't have a contract with Delta Dental, and that's what they wanna charge in short. And so you as a patient, you're gonna pay more money and you're gonna see less savings. And so there's a pro for you to have dental insurance because you pay less out of pocket. As you can probably see if you're in the dental field, how this might maybe hurt you a little bit economically. I'll also say that if you have a PPO plan, you can choose your dentist and you can change your dentist whenever you want. If you don't like your dentist's bedside manner, it's as easy as just finding another dentist that takes your insurance and you can just switch without ever having to contact your dental insurance, excuse me. And so the second type of plan is a DHMO plan or an HMO plan. This is a plan that focuses on preventative care and it costs less. There are typically no annual maximums or deductibles, and there are set copayments, which is what you see on the right side of the screen. I'm not going to go into it, but the out-of-pocket costs for the patient are clearly defined, which is really nice for you as a patient. Your primary dental facility is assigned, which means that if you ever wanted to change your dentist, you'd have to call your insurance company. A little more time. It's not a big deal. It's not as hard as it sounds, but a little less convenient. Likewise, there's a smaller dentist network, and there's no coverage for out-of-network care. And so say you were going out of state and you had to see a different dentist. You wanted to see a different dentist for for a crown because your mother-in-law loves her dentist and wants you to get a crown there. There'd be no coverage for that, so you'd pay out-of-pocket fully. So that's HMO plans. All right, so now touching on the public health and dental insurance. Medicare is a federal social insurance program for seniors and disabled individuals. 2/3 of Medicare recipients have no dental coverage at all. And those who do have it through Medicare Advantage plans, Medicaid, or private plans, like retiree plans through a school district, for example, or just individually purchased plans. These Medicare Advantage plans may have patients paying 100% for preventative services, 50% on all procedures, or may even have an annual maximum of $1,000, which does not get you very far. And this is also variable because Medicare contracts with private insurance companies like Delta Dental, so none of these plans are going to be the same. And so as you can see on the right side of the screen, it just shows that 2/3 of Medicare recipients don't have dental coverage. Nearly half haven't been to the dentist in the past year, and nearly a quarter have spent more than $1,000 out of pocket on dental care, which that's a lot of money. Okay, so Medicaid, on the other hand, is funded by the federal government and states. It covers millions of low-income children and families, and eligibility is based on household income as a percentage of the federal poverty level. So one-person household, they can't exceed a yearly income of around $16,000, which is 138% of the federal poverty level. In California, we have Medi-Cal, which is essentially the same thing as Medicaid, and their dental coverage is called Denti-Cal. And Denti-Cal is a fee-for-service program, which means that there's a set fee that providers will be reimbursed. Mostly patients don't pay, but there are some procedures where patients do have to pay. And this fee that providers are reimbursed is only half of the fees that they would charge for children if this child had no insurance at all, like an out-of-network dentist. And it is about 37% for adults. This is compared to private dental insurance reimbursement rates. That's 80% of the fees charged for children and about 78.5% for adults. So it's low. The reimbursement rates for Medicaid dentists or Denti-Cal patients is really low. Additionally, California has one of the lowest reimbursement rates in the country, despite our high cost of living and our really large population. And this is problematic because it's difficult to incentivize dentists to participate monetarily, although, we're all here, we'd all love to participate from a public health standpoint. But Allegra is going to touch on this in a little bit too. So this graph highlights the uninsured rates by race and ethnicity. If you take a look at the year 2013, that was the year the Affordable Care Act was passed, and it brought down the uninsured rates across all races and ethnicities, which is great. However, you can see that even now, or even towards 2018, there's alarming differences in the uninsured rates by race, with white and Asian Americans having the lowest rates of uninsured individuals, and American Indians and Alaskan Natives, Hispanics, and Black Americans having the highest rates of uninsured populations. So while the Affordable Care Act was passed and it's all well and good, we still have a lot to do in order to equalize the inequalities here. And then to round out my section, I just thought I'd show you the percentage of people that have insurance. And this was done in 2016 when they come into a dental office. So in 2016, 48.9% of patients had private health insurance, which those are the patients that I would deal with at Delta Dental. 31.1% had public health insurance, so that's like Medi-Cal and Medicaid, and 19.1% are uninsured. And so just to really hit it home, 19.1%, they have to adhere to whatever the dentist wants to charge because the dentist isn't contracted by someone if someone doesn't have insurance. So Allegra is going to pick it up from here.
Thanks, Bennett. So yeah, the socioeconomic determinants and insurance that Bennett has discussed pervade all health disciplines, including our own field of dentistry. So socioeconomic barriers and difficulties with insurance can lead to increased caries and disease experience, decreased access to care, and more limited treatment options, all of which I will address in the next several slides. So unfortunately, children and adults alike who are of low socioeconomic status have been shown to have increased caries experience and untreated dental disease. As you can see in the graph on the right, in a report from the Center for Disease Control, the prevalence of dental caries and untreated dental caries is clearly correlated with poverty level and income. So the prevalence of caries in children living in households that are below the poverty level is more than 1.6 times that of the children living in more affluent households that are earning 300% or more of the federal poverty level. And this disparity worsens when we look at the prevalence of untreated dental caries on the right, in which the prevalence is almost 3 times greater in impoverished children than it is in children of wealthier families. So this is particularly important as we all know that caries, especially if it goes untreated, can really affect children's experience and performance in school. So take this photo here at the top. I don't know about you, but I don't think I could pay very good attention in school if my teeth were in pain from decay like that. So children's dental health really affects their education and therefore can affect their ability for upward mobility and jobs in the future. And we continue to see these effects of socioeconomic status on the oral health of our adult population. These statistics on the left come from the ADA's report on oral health and well-being here in California. So as you can see, 29% of low-income adults avoid smiling due to the condition of their mouth and teeth, and 19% of low-income adults reduce their participation in social activities for the same reason. So our smiles are crucial aspects of our confidence, social interactions, and how we're viewed by others. This can significantly impact people's ability to get hired, especially in jobs that involve consistent interaction with people like customers, clients, patients, etc. And then in the same ADA report, 84% of households surveyed reported that they believe that straight, bright teeth help you get ahead in life. If people are experiencing dental disease or are losing teeth, this can make it very difficult to get a job. And then without a job, it's harder to pay for dental care, especially since many people get dental insurance through their job. So it becomes this vicious cycle in which low income and poor dental health further lead to less access to career opportunities and less access to dental care. So I'm going to talk a little bit more about access to care on the next slide. So not only are those of low socioeconomic status experiencing dental disease at a higher rate, but they're also less likely to be able to visit a dentist to get examined or treated. You might recognize this infographic on the right from last week's lecture, but I found it to be a great representation of this disparity and thus reviewing again. So this comes from the Office of Disease Prevention and Health Promotion as part of the Healthy People 2020 initiative to improve the health of the population in the US, including oral health. So one of the objectives of Healthy People 2020 is to increase the percentage of people who have at least one dental visit per year. And the hope is that by more people visiting the dentist, we can help to improve their oral health by identifying risk factors, providing treatment, and educating patients on healthy habits and preventive strategies. So they also identified trends demonstrating what factors can influence whether a person has the opportunity to visit a dentist. So as you can see here, only 29.4% of people whose family incomes were below the poverty threshold were able to see a dentist within 12 months. Now, this is in contrast to 55.8% of those making 400% or more of the poverty level. This is 90% higher than their impoverished counterparts. So clearly, those people living below the poverty line have significantly diminished access to dental care and dentists. Unfortunately, this describes the situation for many Americans. So as you can see on the map on the left, there's still a significant portion of this country with high rates of poverty. And the darker green states are those in which 16 or more percent of people are living in poverty. And then if you look at California, though it is this lighter blue color, it still has 10 to 13% of people living in poverty. If you look at this map, it might remind you of distributions you've seen in previous lectures in which these same areas, especially the South, have lesser healthcare, lesser education, and higher proportions of minority populations. These issues are highly intertwined, and while our focus today is going to be on those socioeconomic factors, I did want to acknowledge some of the factors that have already been discussed. And briefly, I wanted to summarize a few of the barriers to dental care that we have discussed in previous lectures and in this one, which were illustrated in a study reported in the Southern Medical Journal that examined the role of race and ethnicity, insurance, and income on access to care. And they found that Blacks and Hispanics had higher odds, 87% and 77% higher compared to their white counterparts, of reporting no dentist visits in the previous year. This held true even with socioeconomic status controlled. But the impact of income and insurance is still significant, as households in the highest income category had almost 70% reduced odds of not getting dental care compared to the middle income group. And then compared to people with private insurance, those who were uninsured had about 3.5 times greater odds of being unable to get dental care. And those with Medicaid coverage had 84% greater odds of not being able to get dental care. So these data support that these factors such as race, income, and insurance can significantly impact whether people are able to see a dentist to get care. But socioeconomic factors can also have a great effect on what treatment options they do have once they do get to see a dentist. So moving on to those treatment options, I do want to preface this topic by saying that as we have emphasized in previous lectures, we must always present all options to all of our patients, regardless of their socioeconomic status, race, etc. However, we must also recognize that not all patients will have the means to afford what we might suggest as the most ideal option. It's ultimately the patient's decision, and sometimes, unfortunately, income and/or insurance can play a large role in their choice of treatment. So, like Bennett alluded to earlier, some insurance plans only cover certain procedures and might not provide coverage for treatment options such as composites on back teeth, crowns for adults, to replace teeth. As such, I think it is important for us as dentists to be able to provide great quality alternatives for patients who may not be able to afford the more expensive options, or that maybe just need some more time to save money for a more definitive treatment later on. So the image on the top right is from our very own Professor Dr. Greitz, who taught us about large amalgam restorations, which, as you can see in the photo, can be done very well and last a really long time. And they can be a really good option for patients who need a little more time for them to save for that nice all ceramic crown in the future. And it can really help to maintain function for them while they do that. And then this image in the middle is of silver diamine fluoride, which is a great option for both kids and adults. Not only is it really easy and quick to apply, but it's also very affordable and can help arrest the decay to buy them some time whether patients or parents need to save for the permanent restorations or maybe need to wait a little bit for the child to be able to cooperate and avoid the potential trauma and the cost of general anesthesia. I also included a picture of removable partial dentures down below, as they are often covered by insurance and can provide really great tooth replacement outcomes if implants aren't a covered benefit. So as I mentioned at the beginning of this slide, we still have to be sure that we present the patients with all of their options regardless of their socioeconomic or insurance status, and the patient is the one who gets to make the ultimate decision. But like I mentioned earlier, I think it's important to be able to provide good quality, lower cost options so that patients can have some alternatives rather than going without treatment because they can't afford the more expensive options. So we've discussed some of the issues that can arise from lower income or socioeconomic status, but I wanted to also give you some hope about some of the things that have been shown to help decrease this burden and how we can move forward. I'll talk a little bit about increasing access to dental insurance and the amount of benefits offered, increasing reimbursement, and incentives for dentist participation in public insurance like Medicaid, and also incentivizing dentists to serve in low density and underserved areas. So one promising area of improvement is in that of increasing dental insurance coverage and benefits, which is demonstrated by the Medicaid expansion of dental benefits. So after the passage of the Affordable Care Act, 31 states and DC expanded their Medicaid programs, and that number has now increased to 36 states as of 2020. However, only some states offer dental benefits as part of Medicaid, and many offer only limited or emergency-only benefits. So here on the right is a figure depicting data from a study published in October 2019 that evaluated the impact of the Affordable Care Act Medicaid expansions on dental visits. So they found that between 2012 and 2016, individuals in Medicaid expanding states offering extensive dental coverage experienced a 7.5 percentage point increase in likelihood of dental visits, compared with an increase of only 2.9 percentage points for those with limited dental coverage and only 2.2 for those non-expanding states. So as you can see, by increasing the insurance coverage available, this helped to increase the number of people that were able to visit the dentist and receive care. As of 2019, as you can see on the left, only 17 states provide extensive dental benefits, but hopefully if we can work to help increase this coverage in more states through advocacy and other avenues, we can help more people get the dental care that they need. Another promising area of improvement is with increasing reimbursement rates. So as Bennett mentioned, the reimbursement rates are not great for public insurance, but evidence supports that higher reimbursement rates can result in increases in access rate, provider participation, and utilization. So this table here comes from a paper in the American Journal of Public Health investigating children's access to dental care affected by reimbursement rates, dentist density, and dentist participation in Medicaid. So the first box on the left shows that the rate of access to dental care in areas with low reimbursement rates was consistently lower than states with high reimbursement rates. And then they used the data that they collected to predict the rates of access if states were to raise their reimbursement rates, and thereby predicted the number of additional children who would gain access to dental care. So as you can see in the box on the right, hundreds of thousands of children and potentially over 1 million more children in those areas of lower density and participation stand to gain access to dental care if reimbursement rates are raised. And not only could increased reimbursement rates help to increase the access rate, but they can also lead to higher utilization of services and higher provider participation. In this table below from the California Healthcare Foundation, we see the impacts of state dental reforms in Medicaid and how increased reimbursement rates affected these two areas. So this first red box on the left highlights the significant increases in percentage of children utilizing the services provided by their dental insurance through Medicaid. This is really important because it shows that not only do they have access to services, but they're also using them and getting the treatment and preventive care that they need. And then the box on the right shows a drastic increase in providers enrolled in Medicaid after these reforms, indicating that higher reimbursement rates can work to increase provider participation in these programs and thereby increase availability of dentists for these patients. Now let's take a look more specifically at how this plays a role in California. So here are a few statistics from the ADA's Oral Healthcare State Facts about our own state of California. So between 2003 and 2013, Medicaid reimbursement rates for child services actually decreased by 31.6%. And this puts us at just over half of the national average. So unsurprisingly, this significantly lower rate of reimbursement impacts our provider participation in Medicaid, which we see here on the right. This link between reimbursement and participation is clear, and we have seen in the previous slide how other states have shown that by increasing rates, we can improve enrollment and utilization. So as such, we should look to advocacy and reform to help improve our reimbursement and hopefully our state's dental health. Now, while we have shown that increasing insurance coverage and reimbursement rates can have a great impact, if people don't have a dentist nearby that's able to serve them, they can't get the care that they need. This is why it's important to incentivize dentists to serve those populations that are most in need, whether that's rural areas with low dentist density or urban areas with few dentists willing to serve these less affluent communities. All patients deserve to have passionate, competent dentists available to them. So here on the slide, I've listed a few really great programs that are doing just that, providing incentives, mainly financial, for dentists and other healthcare providers to serve these communities. So the first one I have listed is the National Health Service Corps, which provides both scholarships and loan repayment options to providers who agree to work in rural, urban, and tribal communities and federally qualified health centers. I know we have several NHSC scholarship recipients here at UCLA, which I think is a really great testament to the dedication of our students to serve these communities. And then the next one that I have is the Indian Health Service, which is a similar program specifically for those serving American Indian and Alaskan Native populations. And California also has a state loan repayment program, which will help repay portions of providers' loans while they work at federally designated California health professional shortage areas. These are great programs that can help to promote service in these areas in need, and I think it could only benefit us to increase funding to these programs and potentially work towards creating new programs with similar goals. So I think what UCLA has been doing with the community-based clinical education program is a really great step forward in helping to enhance our clinical education and immerse our students in the experience of serving these communities that need it the most. So hopefully some students after these experiences will continue to seek work with these populations after graduation. So as we've shown, socioeconomic factors and dental insurance can have a significant impact on the oral health and well-being of our patients, but there is promising evidence for areas of improvement. So we've outlined 4 different areas in which we as dental professionals can take action to decrease these socioeconomic disparities, organized kind of from big to small, global to local. So on a broader level, we can work to advocate for policy changes such as reimbursement rates like we discussed earlier. So using our voice as dental professionals and citizens can really work toward long-lasting, meaningful change in policy at the local and national levels, including increasing reimbursement rates, creating partnerships between insurance administration and organized dentistry, or even universal health care, but I won't get too political. So next we have dentist density. So like I mentioned, there are some great programs out there advocating for dentists to serve in low density areas. So continuing to build up these programs could be really helpful to increasing dentist density in certain areas. Also, looking to you that are in the audience today, maybe consider where you want to practice. I know a lot of us love California and LA, the Bay Area, or other major cities here, but there are also lots of great areas right here in California that don't have access to a dentist nearby. Or maybe consider moving somewhere new in the US. Or if you're from one of those more rural areas or underserved areas, go back and serve your own community in that place where you grew up that helped create who you are today. And I know not everyone's going to be gung-ho about moving to one of these lesser served areas, but then looking a little further, dentist participation in insurance programs, especially those like Medicaid or Denti-Cal, is another great way to serve lower income populations. So even if you don't accept all Medicaid patients, consider maybe making a small percentage of your patient pool those with Medicaid, or maybe setting aside certain days to serve Medicaid patients. You yourself don't have to treat all the patients, like we've heard, but it is our duty to ensure that all patients do get treated. And then finally, at the more individual level, you can really help patients by educating them and providing resources for them to understand their options. As I mentioned earlier, be sure to learn about and offer alternative, lower cost options if your patients want them that will still provide them with quality care. And make sure you're familiar with different insurances and programs, and especially work with your front desk to make sure that they're able to provide helpful information and explanations, and at least understand where you can direct patients for more detailed information. And then I have an example on the next slide. So here's just a little brochure that Bennett and I whipped up that kind of summarizes the different types of dental insurance, how to get it, as well as some other payment options like Care Credit, if anyone's heard of that, as well as general resources for patients to go where they can get more information. So something like this could be used to pass out to patients in a practice or at community outreach events like health fairs to help more patients understand their options. And we'll also send this out in the recap email later. And so here's a quote from one of our US representatives, Alexandria Ocasio-Cortez. I had actually chosen this quote weeks ago when I was preparing the presentation, but fittingly, just a couple days ago, she actually posted an Instagram story about her own struggles with getting dental care specifically. She was talking about her orthodontics and how she had broken her permanent retainer when she was in her 20s, and due to lack of income and lack of insurance, they shifted. And then she was talking about how Republicans were criticizing her teeth and making fun of how they were crooked, and were trying to use that to then undermine her work in the House of Representatives. And then it was actually her elected position that gave her access to quality health and dental insurance for the first time in years, and ended up helping her save money for the orthodontic treatment that she just started. I think she started Invisalign. So we can really see how these factors can impact people's lives, including in our own House of Representatives. So her quote reads, "I can't name a single issue with roots in race that doesn't have economic implications, and I cannot think of a single economic issue that doesn't have racial implications. The idea that we have to separate them out and choose one is a con." So I wanted to use this quote to remind you all that although we've divided these issues into individual lectures just for, lecture's sake, making it more digestible, they are all intertwined. Racial, social, environmental, economic issues, etc. They're all different faces of the same monster. And we can't look at them in a vacuum, but we have to continue to understand how they impact each other within the system that's been created. And only then can we work towards real change. So we just wanted to say a quick thank you to our faculty advisor for this presentation, Dr. Margolis, and our faculty mentors for SIDE, Dr. Nguyen and Dr. Hewlett. And we did want to acknowledge that it's a very special day. It's Dr. Hewlett's birthday. So happy birthday to Dr. Hewlett. And feel free now to ask any questions that you might have either in the chat or raising your hand, and Fernanda's going to help us answer those.